It's a pleasure to have you to the first of five talks this semester at the workshop on the politics of global health. I'm very, very pleased to have two speakers here talking about the politics of primary healthcare. Kevin Croke is an assistant professor and political scientist at the Harvard T.H. Chan School of Public Health. And Anuska Kalita is a health systems specialist and DRPH candidate at the Harvard T.H. Chan School of Public Health. They'll be speaking today on the politics of primary healthcare. Please help me welcome Anuska and Kevin.
Uh, Great. Well, thank you all for braving the snow and coming here, and thanks to all who joined online, and thanks Joe for the invitation and the warm welcome. Um, I'm going to talk to you today about the politics of primary healthcare. I'm going to do this, as Joe has mentioned before, in a joint presentation with my colleague Anuska Kalita. I think you'll see as we go through the research why we want to do this in a joint way. It's really, it's our research, but it's the research of a much broader group, including teams at the WHO and teams in each of the nine countries that were studied. So we'll be giving you two perspectives on this work, but it's really it's the work of a large team, and we're also excited to get your comments since a lot of the case study work has been done, but the synthesis work of sort of making sense and drawing lessons from the cases is something that's ongoing and that Anushka and I are working on as we speak. So really eager to get your thoughts and comments. Okay. We were approached by a team at WHO who were interested in doing some work on the politics of primary healthcare with a specific focus on what they saw as successful country case studies. And to understand why they had this particular interest, I think it's worth just spending a moment. I know most of you in this room probably have great familiarity with the idea of primary healthcare or PHC, but in a low income or low and middle income country context, it might be slightly different than the way we think about maybe seeing our primary care provider or GP in the U.S. or European setting. We're really thinking about an idea which became especially prevalent in low and middle income countries in the late 1970s and thereafter, and was really symbolized by a famous conference in 1978, something called the Alma-Ata Conference, which was essentially motivated by the idea that the burden of disease in many low income countries was driven by conditions which could often be treated at relatively low cost, sometimes even by non-medical personnel or lower cadres of personnel. But in order to do that, health systems would have to be reorganized so that resources and personnel and medicines would target primary healthcare, would target these sort of dispersed systems of delivery to rural areas, to the poor, rather than focus on the way health systems were often organized at that time and often still are in many countries. That is focused on curative care, focused on hospital care, with more budget and energy going into urban areas and curative care. WHO has long been a promoter of this approach in some form or another, and as you can see from the last bullet here, they've estimated really massive gains if countries reoriented their health system. So over 60 million lives and almost 4 years of increase in average life expectancy, they estimate, if countries reoriented their systems in this way. So you might say, why don't countries reorient their systems in this way? Concurrently, there's been some interest within WHO, which is not typically, I think, thought of as an organization that does a lot of political analysis or really works so closely with political scientists. I think there's been some interest in bringing political analysis into some of their work. And I think most notably, a group of WHO staff who've worked on health financing have seen that to understand how to improve health financing systems, it often makes sense to really also understand what the political barriers to improving health financing are. And I think partially motivated, by the good reception that some of this work has had. Other divisions within WHO thought that they should also bring political analysis into their work, and I think that's why they turned to us. and they wanted to know what political science has to say about these political challenges of moving systems in the direction of primary health care. And to be honest, the discipline of political science hasn't had that much to say about this. I think many people who've presented in this series in the past are part of this growing literature in political science, which addresses global health topics. There's I think a really excellent literature on infectious disease, including HIV. There's great work on universal health coverage by many scholars, including by Joe. Here, of course, many political scientists spent a lot of time thinking about COVID-19 in the last 4 years, and I think just in the last year or 2 years, there have been some excellent comprehensive reviews by Singh and Lynch in the Annual Review of Political Science, which give you this landscape of what political scientists have been learning and publishing about global health. But there really hasn't been that much. There's been some, but I think this idea of the politics of primary healthcare has been a little bit neglected, and so this motivated us to engage with this team. We also thought it's even more critical that we try to train our analytical lens on this, because if you look back to an earlier period in which primary healthcare was on the development agenda, was on the global health agenda, and you could think of this as the period after the Alma-Ata conference, maybe going from the late 70s into the early 80s, a number of countries did try in some form or another to move in this direction. Some successfully, but I think more commonly, more or less unsuccessfully. Countries tried to shift budgets in this direction, have large national community health worker programs, and I think in many ways, this was quickly superseded by different approaches. And if you look back at this period, you often find that in the accounts of why specific countries didn't manage to really go down the PHC path, it often ends up being a political story. Sometimes not described as such, but if you try to understand what the specific barriers were, it's really often about politics. That's maybe my disciplinary bias. I see these accounts and it looks like a political story to me, but I think that's a fair reading of the literature. So as we continued engaging with this program, it's called the Special Program on Primary Healthcare at WHO. They identified 9 country cases that they thought were, really exemplary cases of primary healthcare reform. And they had, or they were going to identify research teams in each of these countries, which could essentially write a case study describing how they had managed success, how there are these political barriers. Somehow they managed to overcome these barriers, and we could learn by seeing how each country did this. But they asked us to engage with the process to provide a kind of overall conceptual framework so that these the findings could eventually be aggregated or synthesized in a meaningful way. Also to advise them on research design and methods. And this is where Anuska really led the work to coach and support the country teams on an ongoing basis as they implemented the field research. And then finally, the stage that we're at now, which is really about synthesis, taking the cases as they've been written and trying to draw out themes and findings. In collaboration with the colleagues in WHO and the different country teams, we settled on 2 overarching questions. The first is, to what extent did politics and political economy factors either contribute to the success or failure of these major PHC reforms? And then relatedly, how did these reform proponents, to the extent that there are common barriers in each country, how did they surmount these? And that's really a kind of application of theory. And the second part, a bit more related to theory building, and this is to think about, does the politics of PHC look like other processes that maybe we have a bit more research on, like the politics of universal health coverage, things that political scientists have studied in a bit more detail, or is it its own thing? Should it be studied differently? And does it really matter if, as you'll see, the nature of the reform is dramatically different? Some reforms start with financing to try to change how care is delivered. Other reforms start with the service delivery system itself and to try to reorganize how care is delivered before tackling broader organizational questions. So these are sort of two overarching questions and many sub-questions, as you'll see, sort of suggest themselves along the way. I think also theoretically, we built to some extent on some work I had done in the past, looking at this period that I just described, this period of post-Alma Ata, when many countries tried and found a sort of set of characteristic barriers to primary healthcare. But then we adapted that to the WHO's PHC framework. And we also use historical institutionalism as a broader theoretical framework. This is kind of a way political scientists often think about large social institutions, including welfare states, essentially. And I think a couple of key features of this are that we like to look at institutions not from a purely sort of the way that a rational choice political scientist might, where you're thinking that institutions arise because there's some kind of equilibrium that needs to be achieved. This approach sort of flips it on its head and says that institutions are emerging from a historical process. We see a strong degree of inertia in social systems, including health systems. And we sort of we look to the factors that create path dependence. And yet, as we try to explain change, and since we're focusing on reform here and successful reform in some cases, we want to understand what are the critical junctures that enable these otherwise quite entrenched systems to be open to change. Okay, so getting to the countries themselves, this was a kind of a classic international organization exercise where we had countries that we wanted to study, but also it was very important to WHO that we have a country, at least one from each of the WHO regions. And so we have two from PAHO. We have Dominica and Uruguay from the PAHO or the Americas region. We had the DRC and Kenya from Sub-Saharan Africa. We have Kazakhstan from the Euro region, Tunisia and Egypt from Eastern Mediterranean and Middle East, Thailand from Southeast Asia, and New Zealand from Western Pacific. And I think the key thing to mention about the case selection process is this is where we sort of departed from, let's say, the kind of academic or research design focus that we might have had when we would try to find well-matched cases and have as sort of careful a research design as we could have from an academic perspective. We weren't really in that kind of world here. We were in a sort of international organization world where we were, having geographic representation. They also initially, the WHO team had a strong focus on only studying success cases. We argued that this is a bad research design. We need some variation on the outcome. They didn't agree with us. And yet, I think as you'll see, and as we saw, and the teams themselves saw when they developed the cases, many of the cases that started out or were sort of self-nominated as success stories, when you get into the details, turn out to be not really or not completely success stories, or in some cases, the reforms were successful and then were reversed. And so we started out with one approach to research design. We were not able to implement that because we were working in the context of an international organization. And then we sort of ended up in a good place in the end because just because of the challenge, I guess, of finding cases that are really, unambiguously successful. We ended up with quite a lot of variation on the outcome. We also have a huge amount of variation on the nature of the case. You can obviously see the geographic variation. As researchers, we often focus or specialize in one area of the world, and so it's really challenging, but it's also really exciting to study different countries, interact with different country teams. This huge learning curve for us as researchers, and that was really enjoyable. But also huge variation in the income level of the countries. the political systems, the level of political freedom or not, the level of state strength and regime type, and also the design of health systems as well. That's something that makes, in some cases, the comparative inference is hard, but also I think makes the work broadly relevant to different kinds of health systems. Okay, so I've told you what the countries are. What I haven't told you is what the reforms were, and I think to describe each of the reforms in detail would easily take the rest of the time we have. So I'll just say a few things. Each of the countries, in some sense, made or attempted a major reform to their primary healthcare system. The two features that are captured in this table are what the main entry point was. In other words, whether the main entry point was on the financing side, that was the case in Uruguay and Thailand, or whether it was on the service delivery side, which was the case for the remainder of the reforms. There's a little bit of ambiguity here. The successful reforms tended to have actually multiple entry points. I see Joe here thinking, I'm sure you're thinking of the Thailand case. There was a lot going on in Thailand, right? You could say the same about Uruguay. It was a comprehensive reform in which both financing and organization and service delivery and governance were all addressed, if not simultaneously, then in pretty short order. But this is a way we settled on as a kind of a way of organizing our thinking. And then in the rightmost column, you have let's say the current status of the reform. And so Uruguay, Thailand, and then Kazakhstan were the most, I would say, comprehensively successful to the reforms. Several of the other reforms, which we've labeled either failed to take off or nascent stages, are as described. New Zealand was fairly comprehensively implemented, but then ultimately more or less reversed. So it's I think uniquely interesting in that way. The other dimension here, and this is another element of working, kind of in a real world situation with an international organization, is that not all of the cases, I think, really captured the politics of the cases. So the way these teams often worked was you had a very senior policymaker, sometimes even a person that directly managed or was intimately involved in the reform, which is great. And then a researcher or researchers outside government who were able to guide that person or collaborate with that person to develop a narrative. What you didn't have in most cases was any political scientists or people that had professional training in this kind of research. And so many of the teams, it didn't matter. They picked it up and they fully understood what to look for. Other teams, I would say, stayed more in a more health services research mode and didn't necessarily capture all of the political elements that we were focused on. And so some of the cases, the reforms themselves might have been nascent, and also the cases themselves, although they were, I think very, very detailed and useful from a health services perspective, had a little bit less of the detail on the political economy. And so the ones that are in dark red, we use for the synthesis, because they had that level of detail about the politics. The ones in the lighter, I guess that's kind of pink, we don't rely as heavily on for the synthesis analysis. All right. As I mentioned before, this was really the work of a very large team. This is both the country teams and the WHO special program staff, and there's Anuska, but I think I had gone to get a coffee or something at this point, so I'm not in the picture. But this is essentially the research team, and not everybody. So some of the country-based teams are not pictured here, but it's really a collaborative effort by, as we said, 9 countries and others. And the research itself, I'll just say briefly, what we did was start with a kind of a desk review of published literature, review of the documents, policies, and the sort of gray literature from each country. And then the country teams then used a range of methods, including stakeholder consultations, focus group discussions, and then most heavily reliant on key informant interviews with individuals involved in the policy reforms in these countries. IRB from local institutions, and mostly conducted in summer of 2023. And then we used a combination of inductive and deductive approaches, really using something from a health system perspective. We use something called the control knobs model, which is a framework within, I guess, within global health to think about how health systems are organized. We used a process tracing approach to the reforms themselves, and we generated country cases, which were then attempting to synthesize. The cases themselves, 5 of them have now been published. They're available on the WHO website. And if you're interested in any of these individual countries in more detail, the cases are all, I think, very good reading. Last thing I'll say before I hand over to Anuska is just what we're trying to do with this synthesis is not to kind of retell the story of any of the individual cases. The reports are very rich in themselves. We're trying to draw broader lessons. And so, as we do so, these cases are very diverse. There's no single PHC reform, quote unquote. But the country cases are kind of individual, very context-specific narratives. And so we're seeking to link the cases to each other into a broader theoretical framework so that we can draw broader lessons. And I think, a constant tension we've had in doing this work is that we have these 9 cases. It's a broad set of cases, but it's not the universe, right? And also the cases that we have, in some sense, more detail and more political analysis of, those may not be the ones that, so we don't have the same level of detail in all cases. So we're going for not kind of universal insights, but what we can think of as a sort of a type of middle range theory that might be relevant to countries, in similar contexts, attempting similar reforms, and maybe also as WHO's great hope for this project was, some new ways of thinking or frameworks that policymakers themselves could take away from this work. So that's what we're hoping to get from the synthesis. And for the actual synthesis, let me hand over to Anuska.
Okay, so with that, let's go into the key findings. First, for research question 1, and just to remind you, this is here to answer this question, we used more of a deductive analysis with a historical institutionalist approach, and this is more of a theory application question. We saw the role of different sort of temporal concepts and temporality, including critical junctures, path dependence, and historical legacies across the different reforms. And path dependence, did create policy inertia. The historical patterns of representation and inequities, for example, were evident in New Zealand in the Maori versus non-Maori populations, which got translated into how the reform was designed, and ultimately the way it was reversed. Entrenched physician interests in Tunisia, conflict and state failure in the DRC were evident in the reforms and how the reform trajectory shaped up. But historical legacies also created positive precedents for reforms, and this is most evident in Thailand's UCS, the Universal Coverage Scheme, which was built on generational investment of PHC infrastructure and human resources. In Kazakhstan, which hosted the Almaty conference that Kevin talked about and had historical links to the core ideas of PHCs, and that continues till today. And Uruguay's sort of history of labor rights, labor welfare, social health insurance really formed how the reform looked for them. We also saw that continuity in political leadership helped strengthen and sustain different reforms. Uruguay had the Frente Amplio government, the party that initiated the reform in 2007, 15 continuous years of the Frente Amplio government, and that helped really establish the government in its initial stages and then strengthen it over years. Kazakhstan had 30 years of Nursultan's rule. Again, the president who initiated the reform. And in contrast, New Zealand's rapid political instability also led to instability in their reform and ultimate reversal. I also want to point out here that Thailand stands out as an outlier with a very resilient reform, which has survived multiple sort of political coups and upheavals over the years since 2002. We also see that most countries with transformational reforms had a critical juncture, either an economic or a political event. Economic recessions sometimes became the impetus for a major health system reform. And this is most evident again in Kazakhstan, Uruguay, and Thailand, which just before their respective reforms went through significant financial crises. In New Zealand, we see that financial crises, both in 2008 and post-COVID-19, actually led to austerity measures and cutting back on their PHC strategy. And eventually in 2022, following the COVID-19 sort of economic slowdown, the reform was reversed. And economic recessions, I'd like to point out that it makes redistribution, the demand for redistribution or the acceptance of redistribution much more than normal sort of economic times, because more income groups the idea becomes acceptable to people across different income groups. Most of the countries went through major political changes. Uruguay had a left coalition in Frente Amplio with an absolute majority in 2005. And that was a huge impetus for the kind of reform they initiated. The populist Thai Rak Thai party came to power again with a majority in Thailand for the first time. Kazakhstan gained independence from the Soviet Union and could move away from a more hospital-centric model, which it inherited from the former Soviet Union. And Tunisia, of course, had the Jasmine Revolution only 3 years before the reform that we study. In New Zealand, the Labour Party had an absolute majority for the first time in the 2020 elections, which is a rarity in New Zealand's electoral system, and we'll come to that a little bit later. But they used that to make, again, some major changes, including reversing the PHC strategy and introducing some new institutions in its stead. Kenya, Dominica, and Egypt, where we saw, if you remember the table earlier, did not have, had mixed results or not very successful reforms, did not really have clear critical junctures preceding their reforms. Context and institutional design, of course, influences the trajectory of reforms, how they are shaped. We see political systems play a role. Although for regime types, we saw that comprehensiveness of reforms and their outcomes were mixed across regime types. For example, Uruguay and New Zealand, both democracies, had very comprehensive reforms and were sustained over time. And New Zealand finally got reversed, but it went on for about 20 years. But so did Thailand and Kazakhstan, mixed and authoritarian governments. And even in the less successful cases, we see a mix of regime types. Electoral reform stood out as a very key theme. And Uruguay and Thailand, for example, had electoral reforms in 1997, just a few years before the reforms were introduced. And that changed the nature of politics to much more programmatic politics versus clientelism, which was there, preceding those reforms. In New Zealand, electoral reforms led to a more sort of mixed member proportional representation and empowered minority parties, including the Maori Party. And because of that, the reforms sustained even when there was a lot of pushback over time during the last 20 years. Partisanship and electoral basis, again, it's not as black and white. So left-right ideology, we found, was not sufficient to explain the adoption and sustainability of reforms. And here, party-voter relationships are neither static nor solely programmatic, and a lot of different sort of dynamic changes affect these how these pan out over the course of a reform. And the best example to illustrate this is actually New Zealand, where the Labour Party both initiated the reform in 2001 and dissolved it in 2022. And the right coalition, the National and ACT parties, were in opposition in 2008. They opposed the reform. But in 2022, when the reform was reversed, they were some of the most vocal sort of opponents of the decision to reverse it. So just to see how these relationships and these ideologies can be dynamic and can shift with time. Most of the countries also had constitutional provisions and legislation, and these helped or hindered reforms in different ways. So in Uruguay and Thailand, there were very clear constitutional provisions with the right to health. The two countries also used, a succession of sort of legislation, a series of legislation to strengthen their reforms over the years. And these acted as institutional safeguards for the reform. In contrast, in New Zealand, which lacks a written constitution, and the Treaty of Waitangi, which is the foundational document of the country, is kind of the source of where all the inequities, the injustices faced by the Maori arise. And this also reflects in how the reform itself evolved over time. We also see that constitutional amendments shaped power dynamics and interest groups themselves. And we see this most in Kazakhstan, Egypt, and Tunisia, where successive constitutional amendments consolidated power in the post of the president over time. In Kazakhstan, that helped to sustain the reform because there were no veto powers. In Egypt, during Mubarak's regime, when the reform we study was introduced, again played the same role. But in Tunisia, this actually had the opposite role, and it led to the failure of the reform. Decentralization and bureaucracies have played varying roles, and it's interesting to see how Thailand's high-level bureaucrats played a very, very key role. And Professor Harris's sort of beautiful term of developmental capture, I think, really summarizes their role in the country's reform. In Kazakhstan, it's really interesting because the akimats, which is the subnational governments or the mayors, they do not have formal veto power, and it's an authoritarian state, but they did exert a lot of informal power over implementation. And we see how sort of implementation pace, whether they adopted the reform, in what way differed based on whether the akims, the mayors, were supportive or in opposition of the reform. Similarly, in Kenya, and we'll see that a little bit later as well, the county governments gained a lot of power over implementation, and also had budgets to spend on their own. Interest groups played different roles. We see a lot of different interest groups, but here we focus on the four most sort of important ones that emerge as themes. The first is, of course, physicians and physician associations, which mostly opposed PHC reforms to varying degrees. We see very strong opposition in New Zealand. In Tunisia and Egypt, they led to they thwarted the reforms in Tunisia mostly, and in Egypt, it led to a kind of a half-hearted implementation over the years. Initially, they were kind of supportive, and then there was a lot of opposition. There was less opposition in Kenya and Uruguay, and we will see that a little bit later. We'll think about the reasons then. And we see a lot of support in Kazakhstan and Thailand. And again, this goes back to how historically physicians have been, very core to, had a public health orientation in Kazakhstan and Thailand, and that through the Rural Doctor Society, etc., which is what might have led to this. Civil society groups, NGOs, health sector experts played a supportive role, especially in agenda setting and policy design. And again, we see them playing varied roles across the different countries, including in formal roles in Tunisia and Uruguay, implementation support in Kazakhstan and Kenya, and policy entrepreneurs in Thailand. Of course, donors and international agencies played a major role, but their roles differed by the country's income levels, their colonial histories, and their politics. And this is much more evident in Kenya, the DRC, and in Egypt. The one other interesting thing we found was that citizens' demand for PHC is not a given, and neither is their support for PHC reforms. And that came out very strongly, especially for service delivery reforms. So in New Zealand, we see public opinion wavered and support for the PHC reforms wavered. In Egypt, Kenya, Tunisia, Kazakhstan, to a large extent, we saw actual resistance by citizens for the service delivery reforms, especially when gatekeeping or where they sort of stopped from going directly to specialists and hospitals, and they were made to go to primary care as the first point of contact. Uruguay and Thailand had high support from citizens, and we will look at the reasons again a little bit later. The politics of ideas, the concept behind reforms, is another important theme to explore, especially from a historical institutionalist point of view. And here, I would like to point out that ideas operate on multiple levels. One is programmatic, where specific design of the policy could come from different ideas, different other programs, etc. And the other is the global or public philosophies. And both PHC as well as universal health coverage, UHC, are such concepts that have influenced each of the reforms that we kind of see in our study. Ideas are closely related to interest groups, especially powerful actors. And over time, they can constrain and empower different actors. And we see this again in New Zealand, where the idea of the reform and the way it was structured as much more of a health governance kind of reform emerged from the long-standing concerns over health inequities and calls for self-governance for Maori, for the Maori. Uruguay, again, like I said, the social health insurance design followed other Latin American countries with strong labor unions, and that's where the idea kind of emerged. Kazakhstan's PHC, the broad definition of PHC, was rooted in the Almaty legacy. Funding and external actors influence ideas for reforms. And like we just discussed, Kenya, DRC, and Egypt were the most sort of prominent examples of this, where their reforms, the reform ideas were almost entirely donor-driven. We come to research question 2, and for this research question, we've used inductive analysis, and this is much more of a theory building piece of the work. And we look at how political economy factors for PHC are unique and how they differ across the different types of reforms. So PHC itself has some unique characteristics. And because of those unique characteristics, they tend to elicit different responses from different interest groups at different levels and lead to different types of tensions. The first area of tension we see is public versus private sector. So usually PHC involves services that have been traditionally the responsibility of the state and needs public sector strengthening. Almost all the reforms that we saw involved a huge component of public sector strengthening. But this also affects private sector interests, especially their income, their autonomy, and patient base, and leads to private sector opposition in a lot of cases. Of course, this we saw was very significantly mediated by private sector power and how historically the private sector in these health systems have gained power or have consolidated, whether they're fragmented or unified, etc. We also see that these play out differently in financing versus service delivery reforms to some extent. So financing reforms that expand the user base for private sector providers by making care more affordable. So poorer people who could not access care from private sector earlier might be able to access care now because the state, the public sector, is paying for it, for example. So these face less opposition, of course, from the private sector. Service delivery reforms that focused on expanding and improving the private sector, threatened private sector and became a competition for private sector, and therefore faced more opposition. We also saw that dual practice, where public sector physicians can work in the private sector or have private practices as well, and that was common in many of our countries, had a more unified sort of opposition. It brought the public and private, it blurred the lines between the public and private sectors, and there was more opposition for service delivery reforms in those countries. The next area of tension is hospitals versus primary care. So PHC usually involves the reallocation of resources and restructuring organizational linkages, say referral linkages or gatekeeping, especially to favor primary care. And this elicits opposition from hospitals and specialists. Again, we see in financing reforms, allocation of significant resources to primary care have faced opposition. For example, in Thailand, in the initial years of the reform, the government actually had to allocate supplementary funds to hospitals because the opposition was so strong, in order to manage that opposition, because there was significant reallocation of the budgets and increase in primary care budgets and reduction, proportionate reduction in hospital budgets. In service delivery reforms, again, there is definitely efforts to strengthen community level teams, which face opposition from hospitals. And we see this very clearly in Tunisia, where the reform could not even get adopted really, and as well as in Egypt. The third area of tension is centralized versus decentralized administration. And again, in PHC reforms, usually there is an effort to empower decentralized administrators. There is increase in their budgets, their expansion of their roles and authorities, and this leads to tensions with higher levels of administration. So again, for financing reforms, we saw decentralized purchasing was very strongly opposed in Thailand, but in New Zealand much more, where and eventually that was one of the reasons that led to the demise of the reform in 2022. Service delivery reforms enhance the roles of decentralized administrators and give them power, especially over implementation and sometimes also over budget allocations, etc., and inevitably leads to tussles with higher level administrators. We saw that in Kazakhstan that I mentioned about the Akims, and we also see a variability in reform outcomes emerging out of patronage politics, pork barrel politics in Kenya and DRC, where counties that are more politically lucrative will be given more resources. The next is physician versus non-physician. And again, PHC usually changes payments of physicians in order to incentivize preventive and promotive care, or to make them take on more primary care services and roles. And it also expands roles of non-physician personnel, usually involving task shifting, where roles traditionally played by doctors would now be played by nurses or community health workers. And this inevitably leads to opposition from the physicians. So in financing reforms, we saw that when there is an increase in patient volumes and overall funding because of primary care reforms, there is physician support. But as soon as you touch their payment mechanisms, there was resistance and opposition. New Zealand is a very good example for that, where the GPs were happy with the program, that it increased their patient base, but they were not happy, of course, with the capitated payments, moving from a fee-for-service payment model. Service delivery reforms, again, strengthen the role of non-physician personnel and directly threaten the monopoly of physicians and the hierarchy of physicians. This emerges mostly from epistemic hierarchies in medicine. And we see this in New Zealand, Kenya, Kazakhstan, Tunisia, to some extent in Egypt as well. The fifth area is expanding versus limiting citizens' choices. So again, PHC reforms that expand access gain public approval, but those that restrict use, especially of hospitals and specialists, for example, face opposition. And this is very common. Gatekeeping is a very common aspect of PHC reforms, where the first point of contact is usually made a primary care provider. And we saw that, especially when that primary care provider was a non-physician worker, the citizens' resistance was much more. And this links back to my point on citizen support for PHC reforms. We also found that citizen support was higher for financing reforms where they had a tangible benefit. So in Thailand and Uruguay, we really saw a lot of popular support for those reforms. In fact, those are, through our interviews, that aspect came about as one of the most important reasons why the reform sustained in Thailand, just the popular support from the citizens. In Uruguay, again, we see this in a very strong way. But in Kenya, Egypt, and Kazakhstan, where the health system has traditionally been very hospital-centric, it has been a really difficult journey to change people's behaviors, especially when you say that now you cannot go to a hospital directly and you have to go to a multidisciplinary provider or a non-physician provider. The last area of tension is selective versus comprehensive changes. And we discussed this a little bit earlier. The way Almata described primary health care, the way the WHO describes it, is a much more comprehensive sort of approach, including many different, and it goes beyond the health sector as well. So many different aspects of the people's lives. And in the 1980s, the selective approach to primary care came about, and there is, again, a different politics of that as well. But that came about, and those conflicting ideas continue till today and get reflected in the different reforms. We found that reforms with simultaneous changes across different policy levels were much more transformative and much more resilient, and were sustained, for example, in Thailand, Uruguay, Kazakhstan, New Zealand to a large extent as well, versus, say, reforms that were very vertical and touched only one or two policy levels and did not have congruent changes across different all the other different aspects of the health system. For example, in Tunisia or in Dominica. So in summary, some of the key points that are important for the political economy of PHC reforms, we discussed temporality, so critical junctures, windows of opportunity, path dependence, historical legacies are important in how a reform is adopted, how it shapes up, whether it is sustained. Context and institutional design is important. Some contexts and institutions encourage coalitions more. Some have more interest groups, some have more veto powers, and these obviously have an effect on how transformational or incremental, or even the pace of reforms. How fast can you adopt a reform given your veto points? In addition, the health system context and the historical sort of legacy of how the public-private mix has evolved in the health system, or how medical pluralism has evolved in a health system, also determines how the PHC reform is adopted and how it shapes up. And of course, there are socioeconomic, demographic, and epidemiological contexts which have been impetus for some of the reforms. Constituencies and interest groups. I just want to point out that, again, these are not static. They're always a dynamic. Different interest groups may oppose or support the same reform at different times, as we saw in in some of our country cases. And of course, even if they support a reform, newer content of the reform might be opposed by them at a later stage. The politics of ideas and the concept behind reforms is important. These determine whether it's sustained through political changes, which donors and supporters it attracts, and how do different stakeholders react to the reform. And finally, the content of the reform. As we saw, PHC has some unique characteristics, and that leads to certain unique political economies, certain dynamics that we need to think about specifically for these kind of reforms. And also the type of reform matters, whether it's financing or service delivery or many other different sort of policy levels might elicit different responses from different interest groups. Thank you. Feel free to write to us. These are our email addresses, and I'm sure we'll have a great discussion.